Hello, I am Jan Leifman.
And I am Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Luis Raez. Dr. Raez is the president of the Florida Society of Clinical Oncology, or FLASCO, the chief scientific officer and medical director of the Memorial Cancer Institute, and the co-director of the MCI FAU Florida Cancer Center of Excellence.
In today's presentation, Dr. Raez will discuss the discovery of novel biomarkers in lung cancer.
Did you know that Dr. Raez has designed and led many phase 1, phase 2, and phase 3 clinical trials with new targeted agents and immunotherapies against lung cancer?
He truly is an accomplished pioneer in the field of lung cancer.
So let's tune in and learn from this global leader.
These are my disclosures, and I do research with many pharmaceutical companies, and I don't get honoraria from any of them. I get only research support. So for the ones that are not very familiar, lung cancer now is becoming very complex. We're going away from palliative chemotherapy that had a very poor result. The survival for lung cancer with chemotherapy historically for more than 20, 30 years is less than 2 years. Now this has changed dramatically because we use, as you can see in this graphic and this table, in the left, we use target therapy. We are going to talk today about biomarkers. Since to the biomarkers, we have identified at least 10 for what we have FDA-approved therapies in lung cancer. We can cover 25% of the patients. And so these patients get excellent therapy to the point that we don't need to use chemotherapy, at least as long as we have oral agents available. And then in the middle, in the right, we are the patients that we still don't have biomarkers. It's not because there are no biomarkers. There are many more biomarkers, but for these biomarkers, we have not discovered the target agent yet. So in the meantime, we're using immunotherapy, and we're still using chemotherapy because immunotherapy needs some help. So however, in the middle, there is an important group. We have identified that the best biomarker for immunotherapy is not a great biomarker, but that's the best one that we have available, PD-L1. If the PD-L1 is more than 50%, we can use single-agent pembrolizumab, single-agent atezolizumab, or single-agent cemiplimab. So we have 3 immunotherapy agents available to be used as a single agent, meaning that 1/3 of the lung cancer patients today can be treated only with immunotherapy, having a good response. However, most of the patients in the right, the immunotherapy alone is not a good option yet. And we need to find new biomarkers that can guide us and tell us which patients will respond, and we can have a better responses. So that's why we still use in most of the patients in the right, a combination of immuno and chemotherapy. So that's a glimpse of how we treat lung cancer patients and how we use biomarkers. So now talking about the patients in the right, the patients that we do target therapy because we have biomarkers. If you remember, when I started to do lung cancer 20 years ago, it was in the middle. Lung cancers were divided in non-small cell, these ones, or small cell. And the non-small cell were either adenocarcinoma, squamous carcinoma, or others based on the histology, meaning based on what the pathologists tell us. What is the histology? However, now, in these last 10 years, we have found, as you can see, that the adenocarcinomas can be subdivided in many different types based on the genetic aberration, the genomic profile that we can identify. And for each of these subtypes, like ALK, BRAF, ROS, RET, KRAS, EGFR, we already have FDA-approved therapies. And there are still genes, like, for example, HER2, AKT1, MAP2K1, and NRAS, that we know that the gene is present. We believe that maybe the gene is responsible of this type of adenocarcinoma of the lung, but we are doing research to identify what will be the agent that target this specific genetic aberration. So in the meantime, despite the fact that there may be a genetic aberration present, the patients still get chemotherapy with immuno because we don't have an FDA-approved therapy for them, or we can put them in a clinical trial. In squamous cell carcinoma in the bottom, it's more complicated because we already have, for example, 6 genes there that have been identified, and we have ongoing trials, but we do not have targeted agents approved for this specific genetic aberration. So there's a lot of work to do. Because that's why, in summary, most of these squamous cell carcinomas, most of the patients go for chemoimmuno or immunotherapy alone because there are no targeted agents. However, everything I was telling you is only at one point of the disease of the patient. Until now, I'm talking about metastatic patients that are most of the patients. What we do a diagnosis, we do a genetic profile, we check the markers, and we classify what therapy they get. But that's only at one point in the natural history of the lung cancer. If we really want to use biomarkers the way that is more rational and perfect and is the future, is this graphic. This is an example of tracking tumor with liquid biopsies. So if you can see in the left, when we diagnose the patient, the amount of tumoral DNA goes up in the blood. So we see an increase in tumoral DNA that we can measure. If the patient goes for surgery, and after neoadjuvant treatment, some chemo, some immunotherapy, something, the amount of tumoral DNA goes down. And then the patient has a recurrence, the tumoral DNA goes up. We use chemotherapy, the tumoral DNA goes down. So this is a more rational way to track tumors that we still don't do it. We are tracking tumors now. We are checking clinical outcomes for therapy with CAT scans, PET scans, X-rays. But I think the future of biomarkers, if you want to take something from this talk, is we need to find a dynamic way to use these biomarkers to track the tumors at any specific time of the natural history of this tumor. So that's why I think this graphic is a good way how using one technology, liquid biopsies, we can track the biomarkers at every single stage of the disease from the beginning to the end. And that's an example of something that we hope to do it sooner than later. So now I want to give examples how we use the biomarkers and how he has been evolving. EFR aberrations are the most common genetic aberrations in lung cancers. And I already showed you that these EFR aberrations are present at the beginning of the disease. But what happened? Once that we treat the patients and we treat with these oral agents, we are very lucky that we have 5 agents for EFR. And the most popular in America, probably everybody knows, is called osimertinib. And there are other ones that we have been using for many years called like erlotinib, gefitinib. Sometimes we have used another one called dacomitinib. Probably the most common EFR in the world is icotinib because it's used in China for more than 20,000 patients. But anyway, that is not enough. So we already identified the biomarker. The biomarker is EFR. This patient has a lung cancer with EFR. But that cannot be it because this patient is treated now. And when the patient is treated, for example, with erlotinib, that's the one that we were using for a lot of years before osimertinib, the patient developed a new genetic makeup. The tumor changed. And what you're saying here is the new genetic makeup of this tumor. And for example, the patient had the original genetic aberration was something called exon 19. And now that you can see in this pie chart is that the 40 or 50% of these patients have a new genetic aberration called T asymptom 790M. So that means that this is a dynamic process. So we already checked genetic biomarkers at the diagnosis of the patient. Now we have to check again because we discovered years ago that this T97M genetic aberration that is resistant to the original erlotinib, gefitinib, and these agents that we used at the beginning, it can respond to the one called osimertinib. That is the one that we use now. So now to avoid all of this headache, we treat everybody with osimertinib as a frontline, but we discovered that we need to test the genetic aberrations when the tumors develop resistance. So that is why it's so important to check biomarkers at the beginning of the treatment and during the treatment, and this was an example about that. This is another example. This is something that we published, I don't know, 3-4 years ago, that this is another patient of us that had one of the most popular genetic aberrations, another EFR exon 19, very popular, exon 19 and 21 are the most popular. The patient was being treated with erlotinib, and he failed. He developed the 7IM resistant mutation, as I just showed you, that we discovered because we tested for the second time a biomarker. And now the patient has progression again. So in this patient, we tested for the third time. So we're not doing gene expression profile or genetic analysis only one time in life. In this patient, we did third. What's the benefit to doing the third time? Now we identify a new resistant mutation called G72S. And this could not be identified if we don't check again. So that's why this is a very dynamic process. And now what we need to do is we need to engineer an oral agent that can overcome this specific resistant mutation. And so we published this short, I think these are 4 or 5 patients with all of these colleagues from other centers in the United States that found the same genetic aberration. And this is another example. This is we published recently this in the Journal of Thoracic Oncology. This is one patient. We published 5 patients because we found with other friends and others. It's the same story here. This is a patient with a EFR LA5AR, originally discovered by the next generation sequencing analysis, a diagnosis. And then the patient developed this resistant mutation called 71AB. Now, we don't have a specific treatment for this 71AB. Unfortunately, these patients go for clinical trial or go for chemo. But now, for example, we know we even have a name for the resistant aberration, and now we need to find an agent for this specific resistant aberration. No? And in ALK, this ALK, for the ones that don't know, is another type of lung cancer. And same story. This is a patient, for example, here is a real story. We have 5 agents for ALK. 5 oral FDA agents approved for ALK tumors with lung cancer. So this patient comes to me for second opinion and said, you know, Dr. Raez, I have failed 3 agents. And my doctor wants to give me chemo. Why he has to be like that? Because I still want to try the other 2 instead to go for chemo. And I told her, no, normally if you fail 3 agents, probably the tumor is very resistant already to the other 2 agents that you have not used. But the doctor only explained to her, he didn't prove to her. So to prove to her, we did a liquid biopsy, next generation sequencing analysis of her blood. And as you can see, the patient originally had only the genetic aberration EML4 ALK fusion in red. Now that the tumor has been exposed to 3 different oral agents, the tumor has developed resistance. And now the tumor has all of these genetic aberrations in the table, ALK J12969, 1407, and specifically the third one in green, G1202. That's a multi-resistant genetic aberration in ALK tumors. And for that specific genetic aberration, it's not worth to try the other 2 drugs that the patient never had because the patient is already resistant. The patient is already resistant. Unfortunately, we tried 3 drugs. Now the patient is resistant to 5, and we were able to identify because we repeated the biomarker analysis with next generation sequencing done in blood in this patient. So in most of my talk today, you are going to hear that I'm using liquid biopsies very often because it's very cumbersome to be repeating lung cancer biopsies. You know, lung cancer always carries a small rhizome pneumothorax, and we have senior people with emphysema. That's why liquid biopsies, you know, a big advocate of liquid biopsies that allows you to repeat the next generation analysis of biomarkers several times with only blood draws. We don't need to do tissue biopsies. So that's why you will talk, I do a lot of these liquid biopsies. And this is another example. When you use, for example, the drug called crizotinib for these ALKs, that's the original drug, the less potent one, you see what are the potential resistant mutations that are going to develop. When you use C, a strongest drug, alectinib, the preferred drug nowadays. Now, we always use the strongest drug. So alectinib is now the preferred drug in United States and the world. The problem is we're using the strongest drug, we develop more resistant genetic aberrations in the, as you can see in the arrows in the right side. Specifically, the first one I already mentioned, G1202R, is a very resistant genetic aberration, and the patient only responds to an agent called lorlatinib. So the other 4 ALK agents don't work. So that's why this is the problem. And the only way that we know about this is if we repeat the biomarker analysis, if we repeat the NGS, next generation sequencing, and as I said, the easy way to repeat, instead of doing another tissue biopsy every time that the patient fails treatment, is to do a liquid biopsy every time that the patient fails treatment and do a genetic analysis, how the profile of these genes have changed. And finally, I don't want to bother you, but this is another example with ROS. ROS is another, uncommon type of tumor, but this is a patient online that you can see in the bottom. He's alive 10 years now with this metastatic lung cancer. As you can see, these genetic aberrations confer a good prognosis. Patients don't have to live 1 or 2 years. Now patients can live 7, 8, 9, 10 years as long as we provide the agents that they need and the research. So this patient already has failed 4 oral agents, crizotinib, ceritinib, lorlatinib, and entrectinib. And he failed entrectinib too fast. And so my guess is he probably was failing entrectinib. So with each of these agents, the tumor, the patient can survive 1 or 2 years. But with entrectinib, you only survive 3 months, and then the tumor progressed. So we did this liquid biopsy, and what we discovered, as you can see in the graphic, is that the patient has developed in light blue a G2032R. This is a genetic aberration that is multi-resistant. If you can see in the chart, in the table in the right, I put a square, a yellow square. This genetic aberration, G2032R, is multi-resistant to all the oral agents that we have for this specific tumor. Everything is in red. That's why it is no wonder why the last treatment only lasted 3 months instead of 2 years, because the patient already has been developing this resistant mutation after he was exposed to all the other tumors. So we didn't have any other choice than put the patient on chemo, because there are no more FDA-approved drugs for this genetic aberration, and we have 2 or 3 agents in research. And so to make the story short, when this patient is going out of clinical trial because he failed again. This happened 2 years ago. But this is an example why it's very useful for us to have a dynamic analysis of biomarkers by next-generation sequencing, by liquid biopsy or tissue biopsy, more than 1 time during the process of the natural course of the disease of the patient.